Thank you for being with us on our fireside chat at the Oncology Brothers event at ASH 2024. Thank you for being here.
I'm delighted to be here.
It was a wonderful session with you and Dr. Rajkumar there, in which you really summarized myeloma, both of you, in 30 minutes. That's an impossible feat, but you did it for our community colleagues. And I'm just here for just doing a little bit of a roundup of what we talked about and just, in general, some messaging to provide to our community oncologists.
Sure.
For the viewers, I'm Sridevi Rajeeve. I'm at Memorial Sloan Kettering in New York, and I deal with multiple myeloma and CAR-T. And I'll have Dr. Costello introduce herself.
Yes, I'm Caitlin Costello. I am local. I'm here. I'm a clinical professor and the director of the myeloma program at UC San Diego.
Wonderful. Thank you for being here. So, the burning question that we all have been talking about at ASH is that of, precursor disease in multiple myeloma, which is specifically smoldering multiple myeloma. There's a lot of interest in trying to halt this disease at the smoldering stage, and there's a lot of approaches and drugs being tested out at this stage. And, the one big trial that has been having a lot of traction at ASH has been the Aquila trial. So, simple question, based on the results that were presented, will your practice change come Monday?
Simple answer, no.
Okay.
I think this is the single most controversial topic, I think, within the myeloma kind of spectrum of diseases. And, I think one of the hardest things for our community docs that I really would like to impart is to say, we got to make sure the diagnosis is right.
Absolutely.
Right? Because just because a patient has 10% clonal plasma cells in their marrow and they have a little bit of kidney disease, I worry that those patients get started on therapy where the kidney disease may be for something else. So I always say the burden is on us to make sure that the diagnosis of myeloma is true. Yep. And then once we've said, okay, yes, they have smoldering myeloma, my bias is that if I'm going to start therapy, I want to know that I'm saving lives. I think these data, including the ones that are coming out at ASH right now, are showing us that we can treat. We can make the myeloma go, I should say, the disease, because it's not myeloma, make the disease go away. But for how long? And does that mean you're going to live longer? So for me, this data here this year shows me all of those things, but not the survival benefit yet. So I'm going to hold out a little bit longer.
Makes absolute sense. Until we have mature data that's actually showing like a significant cure fraction, like our lymphoma colleagues are enjoying in their field, with all the treatments that they have. But in myeloma, the disease biology is different. So if you're not enjoying that sort of survival benefit, should we be subjecting patients to toxic treatment? That remains the question. So I think we will hold out on our judgment and continue the way we are doing right now, seems to be the message I'm hearing, right? Great. Okay. The second, talk of the town, so to speak, has been the new kid on the block, anito-cel, that's coming into the picture. We have been spoiled for choice. We have cilta-cel and ide-cel as two BCMA-directed CAR-Ts in myeloma, and we now have anito-cel that's coming up as a new kid on the block, supercharged, but with possibly less side effects. And then, again, we still need to see it pan out on its survival benefit, etc. But I wonder, given that we have two good options, how would we fit in anito-cel to our practice, and what would influence your choice? Is it an efficacy or safety, or when would you prioritize efficacy over safety, and in whom would you prioritize safety over efficacy?
Wow, good, hard, long question. I think for our community oncologists, the most important message, before answering your question, is to just make the referral. I would love to have this conversation with the patient. And, we know now that CAR-T is approved for second-line therapy. That doesn't mean everybody who needs second-line therapy needs a CAR-T, but it does mean we should be making sure that we are talking about those patients and have a plan, because sequencing is so important in terms of thinking about, I'm going to do this line of therapy first and that line of therapy next. We need to figure out pretty early on where that CAR-T is going to come in. And so which to choose, I guess, remains to be determined a bit. Right now we have two approved CAR-T cells, one probably very clearly more effective than the other. That same one perhaps maybe have a slightly different safety signal as well. So it's a discussion I have with our patients to just kind of say, this is the risk reward. Some of this one may be high risk, high reward, but the other one may be less reward with less risk. And kind of talking through those a little bit. I'm very excited for anito-cel, perhaps offering similar efficacy to our best CAR-T that we have now, perhaps with all the lesser risk we've seen as well. So I think stay tuned for our community oncologists, make those referrals. We want to talk to those patients so we can make this decision together.
Absolutely. And just going down the CAR-T path, so we see our referrals for CAR-T patients, and how early do you transition patients back to the community oncologist? Because sometimes, patients would want to stay with the CAR-T center, and we tell them that it's probably not needed because they can go back and get some of the post-CAR T care with the community oncologist. So how early do you feel comfortable to transition them back?
I think a numerical number, I would say I wouldn't do it before 2 months. But I would like to make sure that the patient's stable. I want the patient to be able to go back to the community oncologist and know that we have a plan in place, because there is some lack of predictability about CAR T sometimes. And sometimes you have to wait that out a little bit to make sure that things are not going to change next week.
Exactly.
You know, so I'd like to see that the blood counts are a little bit more stable and that they're holding their own pretty well. I'd like to make sure we have a good plan in place for disease response assessment, you know, so that I can hand them back to the oncologist and say, it worked, they did great, they're in an MRD negative, stringent complete, you know, response at this point, and do this from here on out. Now, we still connect with those patients. We want to see them every few months, you know, eventually get to once or twice a year perhaps. But I really encourage them to go back to their oncologist most of the time they need to. Perhaps they live far away from my CAR T center and they need to get home to the people who know and love them. And from a convenience perspective, I think need to be with their community oncologist. So I think the first couple of months, when the acute and subacute, if you will, you know, effects can take place, I'd rather know that those are behind us before they go back to their community doc.
Yeah, absolutely. And in a similar vein, you know, we do see patients for bispecific referrals as well, and they are admitted with us, or we do them in an outpatient setting, and then you transition them back. So when you transition them back to the community oncologist, is it usually the same timeline, like 2 months, or do you probably follow them longer before you transition them back to the community?
I would even wonder if it could be shorter. I think practically, we know that the kind of more risky time period is that step-up dosing, right? So that's where they really within those first 4 weeks. The first 4 weeks and arguably the first week and a half, depending on which bispecific you're using, you know, once you get them through to that first treatment dose, the likelihood of them having CRS or ICANS is very low. So if within that first cycle things have gone well, I kind of write up a little plan, just review it with the patient and the community oncologist and say, they did it. We're out of that window of toxicity, acute toxicity. Now let's focus us on longer term toxicity and make a game plan moving forward so the patient continue receiving that drug with their local oncologist.
Absolutely, and that's an important message that, you know, once patients come to a tertiary center, it's not like the community oncologist loses them, quote unquote, right? You know, it's just, you know, they go from the driver's seat to the passenger seat. We sit there for quite, you know, a transient period of time, and then the driver's seat goes right back to the community oncologist. So, and that's how we like it also, you know, as soon as possible, reintegrate them back into the community. Dr. Costello, thank you so much for being with us here, and I look forward to the final program where all your pearls of wisdom were shared today.
Thank you so much for having me.
Of course.